Okay, we're ready. Good afternoon. My name is Janie Gordon, and I'm with the Mid-Atlantic Public Health Training Center, and I want to welcome everyone to today's Public Health Practice Grand Rounds, both our live audience and our online audience. Today we'll be addressing services for older adults, a changing landscape for in-home care, which is a topic particularly of interest as the baby boomer generation continues to age. I have a few announcements before we get started. For people who are watching online, please check out our archived Grand Rounds and other online trainings. Our next Grand Rounds will be February 19th and will address current issues in domestic violence. For those watching online, you can email a question for today's presenters at any time during the presentation by simply clicking on the link, or you can send your email to maphtc@jhsph.edu. That's a mouthful. At the end of the presentation, there'll be a slide that has the email address as well. I'd like to introduce today's speakers, and both speakers will do their presentations, and then we'll be open for questions and discussion. Arnold Eppel is the director of the Office of Aging for the Baltimore City Health Department. He operated a 300-bed long-term care senior community and was the director of the Baltimore County Department of Aging for approximately 20 years. He currently serves on the Johns Hopkins Mental Health Advisory Board and is treasurer of the Maryland Gerontological Association. He has a master's degree in geriatric management from UMBC and a BS degree in accounting. Sarah Szanton is an associate professor at the Johns Hopkins University School of Nursing with a joint appointment in the Department of Health Policy and Management at the Johns Hopkins School of Public Health. She tests interventions to reduce health disparities among older adults and particularly focuses on ways to help older adults age in place as they continue to grow older. Dr. Szanton completed undergraduate work in African American Studies at Harvard University and earned a bachelor's degree from the Hopkins School of Nursing in 1993. She holds a nurse practitioner master's degree from the University of Maryland and a doctorate from Johns Hopkins. She is principal faculty of the Center for Innovative Care in Aging at Hopkins, as well as core faculty at the Center on Aging and Health, the Hopkins Center for Health Disparity Solutions, and is adjunct faculty with both the Hopkins Center for Injury Research and Policy and Arizona State University. So we have two very talented and experienced people to address this topic. So we're going to get started now. Mr. Eppel?
So good afternoon, and I wish everyone a happy New Year. But with New Year's comes many changes that we always see, whether it's in weather or, in this case, in health programming. So it's a pleasure to be able to present this. I'm going to present you both a national as well as a statewide and even a local perspective of aging services and how it's evolving or changing. And I want to give some real credit. First, I want to begin by talking about the vision that's happening at our state level, whether it's working through the governor and also through Josh Sharfstein and Chuck Milligan, who've been very instrumental in fast-tracking a program of home and community-based services and moving toward or away from institutional bias of Medicaid dollars. And that's truly what you're going to hear a little bit today as we look at the population trends and as we look at how dollars for older adult programming need to change based on the baby boomer and based on the many people in population that we're going to see. So first I present to you a 2010 population of just Maryland for the 65 and over population. And you can look at Baltimore City and you can look at the surrounding counties. And as we look, you're looking at numbers, let's say around 14, 12%, but specifically in Baltimore City, you'll see 11.7%. Now, the next slide was difficult to make a copy of, so pardon, it's a little bit more fuzzy. There are two fuzzy slides. They're right at the beginning. They're both pictures, so you get the 1,000 words. And you can begin to look at Baltimore and Baltimore City as it begins to change as we look at projected numbers of 2020 and know what kind of folks that we're going to be serving as we move forward, and the population and the sheer numbers that we'll be trying to help as everyone grows older and we have higher longevity tables. These are some of the programs that currently provide long-term support services, and this LTSS is significant because this is a new data entry software piece that we're required statewide to do our information sharing, and this comes with a standardized case management tool as well as a billing module built in. So that's why I kind of referenced LTSS, but these are the programs under the Department of Health and Mental Hygiene. You're going to hear about the home and community-based waiver. And don't let that scare anybody, because waiver basically is just that. I don't want to go into a nursing home, and I'm nursing home eligible, and I'd like to receive services. I want to waive that and get services in my home. So that's the waiver program. Medical Assistance Personal Care Program, someone that needs just some light assistance to be able to live in the community. And then there's the PACE program, which is an all-inclusive model of elderly services that CMS has funded in the past. The Maryland Department of Aging has a grant called Senior Care. It's a small grant. In Baltimore City, for example, it's about $1.3 million. And we may put about $500 to $2,000 worth of services into a person's home over 65 to keep them in the community. There's the Veterans Directed Home and Community-Based Services model that we're hearing more about. That's a national perspective. And then there's caregiver subsidy services through the Older Americans Act. The Maryland Department of Disabilities has an attendant care program, and then the Department of Human Resources has an in-home aid service and project home. So that kind of gives you a full summary of the many kinds of services one can take advantage of depending upon age, requirements, income, assets, et cetera. And they all vary by that criteria. Second fuzzy slide and last one you'll have to look at. This gives you an analysis of what the average cost is of someone in Maryland who lives or receives services inside a nursing home. And then you'll begin to look very quickly at what a waiver service can cut that cost down to. And we always talk about cost neutrality when we look at waiver services. And so what we do is we always look to say we're not going to spend more than that $70,000. But what it really averages out to is what you can see on the screen, around $32,600. And then assisted living subsidy, which is a small little program. And then our senior care, which I mentioned a moment ago, is about $19,000 or almost $2,000 a person to keep them out of the nursing home, the expensive and program. And then there's the congregate housing. All right, so what trends are we seeing locally? And what are we beginning to see here just in Baltimore City? And so I kind of gave you this perspective of nursing homes are beginning to utilize, and I'm not telling anybody something we don't know, they're using their beds for more of the rehab. The reimbursement rates are higher, and the desire and need to fill these beds, census issues, et cetera. In Baltimore City, we've seen 3 nursing homes close in the last 2 years. And I've listed them for you so that you can see it's a total of 436 beds. Now, whether they'll end up coming back into play or not, I can tell you there's a waiver on 2 of those, so more than likely they probably will come forward. And check this out, the final bullet, assisted livings. Look at the tremendous increase that we're seeing in assisted livings just in Baltimore City. You're seeing a 20% increase in 2012, or an additional 315 beds to 378 beds. That's 63 more assisted livings that have popped up. And we're talking the 1 to 4 beds. You could be talking 4 to 15, but you're talking about new and models of businesses that are popping up in the community. And those that have to be looked at and regulated, they all fall under what's called COMAR 1007-14, which regulates both assisted living and nursing homes and hospitals. So, area agencies on aging, and that's what where I come. I'm the director of the Baltimore City Office of Aging, working for our health commissioner, Dr. Barbeau. And the Office of Aging is charged with many of these programs that you'll see changing. The one that you'll see here is through the Older Americans Act. It's called CDSMP. It's the Stanford University Model, Chronic Disease Self-Management and Chronic Disease Self-Management Diabetes. And these are done through lay leaders, and they're done through folks that are interested or have chronic disease themselves. They kind of run their own show, and they kind of teach each other some of the ways in which they deal with their chronic disease. It's 6 sessions. We run these around the city. The problem is the sustainability on these CDSMP programs are poorly funded, and so we've kind of turned to that fourth-year nursing student that has to do some work in the community to help operate and run these projects. And so the CDSMP program will continue to evolve and be one of the core elements of keeping folks engaged inside the community and looking for best practices that maybe a consumer themselves who has chronic disease can help with. We're watching CMS Innovation Grants. Various models are being implemented. Here locally, we have the J-CHIP that Hopkins has, and we have the Coordinating Center project operating using the Coleman model. The Coleman model being a more of a coaching model and helping people with their discharge from the hospital. It basically looks for resources in the community. It deals with making sure that you fill your prescriptions that you came out of the hospital with, that your physician ordered, that you make your follow-up appointment, that there are red flags being understood by the consumer, and that they have short-term goals. Short-term goal may be, I just want to see Johnny at the soccer game in 2 months' time or a month's time. It's keeping that readmission back from the hospital, that 30-day readmission. And so that's the CMS innovation projects that we have here locally in Baltimore City. And of course, some caregiver pieces that we're watching that are coming out of CMS. I don't think I did. Hopefully I didn't double click just now. Anyway, here's the Medicare Enhancement, including preventive care services. So we're seeing annualized wellness visits approved for folks without copays, which is encouraging older adults to see their doctor more often. Out in the community. And we see the Part B preventive services have now waived the 20% copay, moving towards 100%. And of course, there are some exceptions that apply with that, but a number of preventive services are now being covered. A real move under ACA to close the donut hole for the prescription drug program by 2020. And the Medicaid waiver, the focus on preventive care. And we just read about that in the Baltimore Sun these last week, of a real change in what's going to happen as far as getting community services working with hospitals and hospitals working with community. Understanding hospice, and a piece that we've been doing locally is by educating the underserved populations to decrease utilization disparities. In a moment, I'll show you a slide of utilization disparities in hospice. And the focus really has been two-part. Number one, educate our religious leaders, at the same time making sure that people understand what hospice really is and what it can do for a family. We just held an outreach project over at Morgan where we had 350 religious leaders understanding myths of hospice. So we're trying to educate the underserved population. We're concentrating on the limited access, which we don't have here in Baltimore, limited access like we have in some of the rural communities, and understanding the difference between palliative care and hospice services. And making sure folks understand that just because you have hospice service does not mean you have to be institutionalized, because 95% of all hospice is maintained in the community or at home. So look at this disparity of hospice services here just in the state of Maryland, where Baltimore County is showing a 52% use of hospice service for every death in 2011, and that's the best data I could get. And then look at Baltimore City in 2011, and you can see that we are at 23%. And Baltimore City and Baltimore County are not too far apart from each other, but they are light years apart in the disparity of use of this health benefit because people misunderstand it or don't trust it. There's a number of reasons why, and so it's breaking that barrier. So what current reforms are happening? And this is where the gist of the program really is that we're talking about this morning. And this is where the concentration really needs to be with each one of you, because these are the big changes coming down. The Community Options Waiver, and you can call it CAL or whatever you might want to call it. I'd call it CW. is a merger of two waivers. It's a merger of the living at home, and you'll hear LAH, and then you'll see the older adults waiver, OAW, coming together as one succinct program. You're going to hear about the new Community First Choice Program, CFC, which is created under Section 2401 of the Patient Protection Act under ACA. And then the Balancing Incentive Program, and I gave you a break, I didn't call it BIP, but it is called BIP. And then the Maryland Access Point, MAP, and ADRC. ADRC is Adult Disability Resource Centers that's happening on a national level. Here in Maryland, it's called MAP. And then the final piece of the puzzle is the money follows the individual or person, and applying for a waiver regardless of the budgetary caps that are in place for the waiver program. A person in a nursing home will have first right to try to leave that nursing home if they can, at least restrictive environment, and it's person-centered decision-making and care. And so you'll see as we walk our way through it, and you probably have 1,000 questions. Watch how this PowerPoint evolves to answer those questions, all right? So the Reform Medicaid Long-Term Services Support, and if you remember LTSS, remember I talked about that? It's the software that has been built and that we're all doing this similar data entry into, whether it's care, take notes from nurses to caregivers to billing. It's all involved. So the home and community-based options waiver has been merged for the older adults, as I said, and living at home. Second is this Community First Choice coming around in April. And the third is the Medical Assistance Personal Care, MAPC, which now requires an AIRS assessment and a support planning assistant. So those are all technical changes that are going on under the MAPC program. So the redesign of two of the programs that are in the blue above will provide a better health, safety, and additional quality of life for home-based services to be rendered. This is really important because you can have these folks getting the services in the community, in their home, but if you have folks that are aunts or uncles doing the caregiving, and for many reasons why, you need to have some eyes on these folks. Because it could be possible that someone's developing some real health problems at their home and not being addressed. And so that's why the importance of this merger has happened and this additional framework that's been added. And as I said, Josh Sharfstein and company have really taken a look at this and really made sure that those safeguards are in place. So I say that to you because that's really important because we administer the waiver currently for the older adults, and I know what I know. The MAPC program now requires an AIRS evaluation, which we've not had up until now. And it begins almost, what has already begun actually, began the first of the year. This will help in the delivery of tailored services. So how do we know what a person needs if they have medical assistance? They say they need some personal care. Well, what is it they exactly need? We didn't do an assessment. We just did a look-see. Now we're doing that assessment through what's called an AIRS assessment using an Interi tool, which I'll talk about in a moment. So now we get specific assistance on which ADLs they need, activities of daily living, along with a support planner that's going to be provided effective the first, which has not happened prior to. The plan of care will include a strong emphasis on the individual's personal choice, and that's a big change as well. New service structure, we have two 1915 waivers, as I talked about, being merged. It reduces applications. We're now using one application. We offer a full menu of services to waiver participants, and you'll see, because in the next slide I'll show you what was and what is as far as a full menu of waiver services. And you'll see that some things weren't covered under the living at home waiver and the older adults waiver. So you'll see the difference. And it simplifies the administration of the waiver process. The Community First Choice service currently offered under the Living at Home and Older Adults program will no longer be offered as waiver services, but offered through Community First Choice. So someone that may have gotten waiver or sits on a registry may get some services and additional services as well. There were a number of folks and continue to be on the registry, which is not a waiting list, but a registry for waiver. And so this will help in trying to get through that registry and get some folks signed up for services. It'll maximize a federal match under what's called the CFC. There's additional federal dollars that'll come to the state, and it resolves inconsistent rates and policies across programs, and there are payment rates to providers, et cetera. And so we'll talk about that in a second. The new service structure for MAPC is as follows. The medical assistance personal care will remain in effect for individuals who do not meet institutional level of care, and that's really important. These folks are not nursing home eligible. They are eligible with a light amount of work in their home to keep them in the community, or they'll just fall into nowhere's land because they'll end up in your hospitals is what will end up happening over and over and over. And so we need to look at that as a tool. MAPC participants will mimic the CFC program in the manner in which we reimburse. Up until now, we reimburse folks on an hourly basis. We are now mandating that our care providers call in when they get to the home to take care of someone and call out when they leave that home. Everybody get that? So now the way they're paid is when they make that phone call into the system, and when they leave, they make that phone call out. And that 1 hour of time is truly spent in that individual's home versus an invoice that's sent in and someone signs off that they were there. So they actually have very good accountable changes that have been put in place. If a person does not have a landline, the care provider must have a cell phone. She has a little magnet that's attached to the individual's refrigerator that has every 5 minutes a number changes, and that's kept at the person's home. So there's good internal control about how much time a person's spending caring for someone inside the home, at least time-wise. Individual participants will select and meet a support planner. They'll determine their desired level of self-direction. They'll develop a new plan of service with an individual budget and hourly personal assistance services enrolled by April 1st. The MAPC case rate will be effective for people remaining in MAPC until April 1st, which means currently no change in reimbursement models that are applicable till April 1. All right, errors evaluation, and then you'll see the changes in the actual service levels. So effective, I think it happened around September, October. All of the health departments around the state moved into something called Interi. Interi is a web-based tool for assessment. We were using what was called the Adult Evaluation Review Services Assessment Form. It was very, everybody was using it, but there was a lot of objectivity to it. I shouldn't say that. There was a lot of subjectivity to it. This is a scoring model. So the Interi gives you a score, and you score in what's called a RUG, a Resource Utilization Group. And depending upon how you score 1 through 7 is depending upon what service you get, whether it's MAPC, whether it's Community First Choice, or whether you're eligible for the Medicaid waiver. So the Interi will be used in all those programs and included now under the senior care program that's funded through the Office of Aging, and also the assisted living subsidy, as well as the congregate housing and adult medical daycares are all on the horizon. That will probably happen by I'd say mid-2014. And these are the changes. So Interi will be part of any of those subsidized programs. All right, exhausting, right? There's a lot here, so there's a lot to digest. So here's the MAPC program that's currently in place. There's the living at home waiver for those over 18 and over. And then there's the living at home, and then there's the older adults waiver, OAW, or WOA, whatever. Older adults waivers 50 plus, living at home was for those disabled 18 plus, pardon me. So if you notice under living at home waiver, you won't see assisted living paid for, you won't see balanced behavioral consults paid for, or eligible for the final area. MAPC, there is really no case management. The nurse case monitor is the case manager. And so that becomes a little difficult. And so let's go to the new change, okay? Everybody digested that? It's pretty much the same. You'll see a changeover. Now, there is the 3 changes. Waivers are merged, Community First Choice evolves, and the MAPC program is by itself now with having a support planner and a case manager, nurse monitor separate, and a personal assistance services that are in play. That whole frame now will get an Interi errors assessment, they'll get a RUG, and they'll fall into one of these 3 categories. The waiver program now includes assisted living for everyone in the waiver, not just for the older adults, but it also expands the service options for those that are disabled. So if they want to get out of that nursing home, there are other options besides sitting in a nursing home or trying to figure out how they're going to go into the community under a waiver program without assisted living paid for. Everybody with me? Okay, no, you're not with me? Anybody need to go back and look at the prior slide? It's complicated. This is, if it wasn't complicated, we wouldn't be sitting here learning. So that's what we're doing together. All right, so rebalancing principles. The improved access to home and community-based services. Who wants to move into a nursing home? Nobody. Who wants to stay in the community? Everybody. But is it possible for everyone to stay in the community? And that's the rebalancing, or change from institutional bias of Medicaid dollars back into home and community-based services. So we need to try to eliminate the barriers for someone who wants home and community-based services. We're coordinating services and increasing collaboration between agencies outside of the institutional level and inside the community. And we're enhancing person-centered focus. This is what the individual wants. We're shifting the focus from that institutional spending to the home and community-based spending. Increasing self-direction would give the consumer what they want and take advantage of the opportunities presented under ACA for folks to be able to balance their life based on how they want it to go and how they see it, not how we see it. This is the projected state enrollment in each of those programs. So it gives you a little advantage of what we see in a larger way. Certainly can at least start to begin to serve more people utilizing the federal enhanced match under the CFC. And so this gives you a little advantage on a statewide basis. Here's the Maryland legislation that established what's called an ADRC, and that's important because you're going to say, so you showed me all this, great, how do we access the service, right? How do I get a patient enrolled? That's where we're going next. So the Maryland legislation established in 2013 that the Maryland Department of Aging would be that Adult Disability Resource Center, ADRC. That's a national term. And they established something called a MAP, Maryland Access Point. It defines what options counseling are. It identifies statutory partners that are mandated. And it defines how the ADRC will work in Maryland. So Maryland Access Point is born. You're linked to health and supportive services. There's the website that the state is putting out there. And this has both public and private programming or support services. Here's how you access the MAP. So now statewide toll-free number has not yet been established. It will. It should come out probably in sometime in April. I'm going to show you all the numbers, and that's why you're going to say, oh, I understand why a 1-800 number is coming. Anticipated statewide in early 2014. In Baltimore City now is the 410-396-CARE number, C-A-R-E, or 2273. The website is underway through the State Department of Aging and working with many other partners, including those with brain injury, the Alzheimer's Association, and others. In person, there are 20, in total, there are 20 MAP sites statewide, and we are coexisting with what's called a CIL, Center for Independent Living, both in Baltimore City and Baltimore County. These are the folks that represent the disabled community, the disability services. These are your peer mentors in disability. They will help go into nursing homes and help educate and move or work with folks that want to leave a nursing home that are disabled. So we have a close tie. They're actually in our call center 3 days a week. Adult Disability Resource Centers was designed to integrate both aging and disability services. It creates a single point of entry for information for telephone screening, support, and services. It's support for the caregivers. It provides options counseling for folks that call in, don't know what to do with my mother. I'm dealing with the following. And the website includes both local and private resources I mentioned. So there's your numbers, depending upon where you live in the counties, in the state of Maryland. And that can get pretty confusing. And where do I call next, right? These are your area agencies on aging across the state of Maryland. You'll see Baltimore City, 410-396-4932, and the county, and et cetera, okay? So you don't need to memorize that. So this is what you'll see very soon coming for this area. It's the Community Resource Directory. It'll be out next week, 2014, for both Baltimore County and Baltimore City. This is a public-private partnership that we put together. We did this first last year in 2013, so that we have a regional approach to both services, both public and private. It also has all the benefits for older adults and disabled listed in the resource directory. It's about 102 pages long, and yes, it will be sitting on the web under the health department probably in a week's time. Actually, I just sent it over this morning to be posted. The hard copy will come out next week. So now let's move into what's called options counseling, and money follows the persons. Options counselors assist those persons living in institutional care to consider transition to long-term care. Moving back into the community, there's a question called Section Q under the minimum data set that everyone's required to get during the admission process. It requires all patients to have be part of the goal setting of their own person. If in fact someone says, yes, I want to transition out of the nursing home, they have to have another AIRS assessment, now called inter-I, right? And they'll have an inter-I. We'll go into the hospital, we'll do an inter-I assessment and determine their ability to move out of the nursing home. Now you can imagine all the conflict and pushback they're going to receive from family who kind of made a conscious decision, as well as the nursing home who looks at census, but the person has the right to choose. So we have area agencies on aging. We talked about SILS a minute ago. Go in there and do some peer mentoring, trying to educate them on folks that successfully did move out of a nursing home and how they did it. And then we work with that individual even to look at a place for them to reside, as well as the service coordination to come into their new place, whether it's assisted living or they chose another option for living outside of a nursing home. Money follows a person was approved by CMS and developed to allow people to transfer their Medicaid institutional funding back into a community setting. And they are the highest priority. They're number one. If they want to leave, we can help them move their Medicaid dollars that way. MFP, money follows the person. Participants generally receive their services through an existing waiver program. And so that basically when they move out of that nursing home, they're under the Medicaid waiver program. The additional services are available to the money follows the person coming out of that nursing home. Just these folks are eligible for housing assistance, behavioral health specialists, flex funds, and peer mentoring. We'll give them about $3,100 for them to move out of the home. It might have to pay for a bed. It can't pay for things like a TV or radio. It can pay for things that would go in the kitchen and other ancillaries, keeping clothing, etc. Will actually help with the purchase of those products and then reimbursed. So let's focus back out now and let's look at advanced directives. And because we're looking at that whole gamut of service now. So I want you to look at this as it relates to advanced directives for folks when in fact they move into or they have to go to a hospital. Look at some of these statistics. 60% of people say that making sure the family is not burdened by tough decisions is extremely important to them. But 56% of them, or over half of them, have not communicated their end-of-life wishes. 70% of people say they prefer to die at home, but 70% actually die in the hospital. 80% of people say if they're seriously ill, they want to talk to their doctor about end of life, but 7% actually do it. 82% of people say it's important to put their wishes in writing, but 23% have actually done it. And 34% of Marylanders report having advanced directives. That means 2/3 of us have not put in an advanced directive. And it's as simple as a 5 wishes document, which is free, or the Attorney General has a website. You can download the document and fill it out. African Americans are significantly less likely to have one, thus identifying another health disparity as it relates to end-of-life programming. So, I know that was exhausting. I know that was quick, but at least it gives you a perspective of what's happening both in Baltimore as well as in Maryland and some of the CMS initiatives. Thanks.
Good afternoon to everyone in the room and online. It's always terrible to follow my good colleague Arnold, who has the amount of energy as 20 normal human beings. I'll let you take a deep breath, absorb what he said. My talk is about one particular program and its potential policy possibilities. And I have only one modification to Arnold's talk, which is we are one of the CMS Innovation Grants also. So Johns Hopkins has 2, the JTIP that he mentioned and our Capable program that I'm about to discuss. So you just heard about people wanting to age at home. And I think that as clinicians and public health practitioners, it's important for us to remember the significance of home and why we care about health, right? We tend to see people in clinics or in hospitals, but where they function is where we want them to be healthy, right? We see them for a tiny fraction of time compared to what their lives are. So I always like to start with a picture of home. Also, you'll see there's no railings on these steps, which is very common in Baltimore row houses. I wanted to start with a particular participant. She was in our pilot study. This is Mrs. B. She's 85. She has arthritis, congestive heart failure, and diabetes. She's very weak. And if any of you are clinicians in the audience, if you saw her in the clinic, you would probably ask her about her blood sugar, her high blood pressure, is she taking her medications? But are those the things that keep her out of a nursing home? Are those the things that keep her functioning at home? Very indirectly. And those aren't the things that patients care about as much. The 50% of community living Americans have a chronic condition. Like I have asthma. I use an inhaler. I probably cost the healthcare system $50 a year, probably, really. But the 14% of Americans who have a chronic health condition who also have functional limitations cost almost half of all healthcare spending, not including nursing homes. So these are very high-cost users. It's a good place to focus is function. And of course, function matters for everyone, right? It matters for Mrs. B. It matters for her family because they can be less worried and carry out their daily lives. It matters on a societal level. I don't know if you know this, but I heard this recently. For every senior citizen now, there's 2 baby boomers. Just as a perspective, if you think of all the older adults you've met, there's 2 of them coming up, right? And as Linda Fried often says, they're our biggest growing natural resource, right? And so the more functional and happy and engaged they can be, the better off our whole society is. And then, of course, from a taxpayer or cost perspective. So back to Mrs. B. She was a domestic, so she's got no pension. She's worked for a family. She is lucky in that she's got a grown grandson who's a truck driver who comes through town and fills up her refrigerator every once in a while because she can't get down the stairs by herself outside. She's also lucky that she has a bathroom on the first floor. But she spends almost all her day in that chair. And in front of her is a TV, behind her is the bed, and that is, the window is actually her front door. She stays on her first floor. And this is her closet because there's no closet in a typical dining room of a row house. And it's safety pinned together, and her arthritis is bad enough that it's very hard for her to get the safety pins open. So she has a difficult time getting dressed. This is her floor after we fixed it. And there were holes all the way throughout, and including a 2-foot by 1-foot hole right before her front door. And I'm not allowed to move because this is taped, but you can picture an older adult shuffling gait, right? Like as we get older, it's even more important that there aren't holes in the floor. Even though for any of us in this room, we wouldn't want holes in our floor. So you might say that she's safer sitting in her chair, but from a health perspective, sitting in a chair all day long is a terrible idea, right? It increases the likelihood of you circling into frailty. You're not eating as much, you don't have the appetite, then you can't stand long enough to cook the food for yourself that you need, and it goes on and on. Well, and well, you know the demographic transition, we're going to have a massive amount of older adults. And one of our largest priorities, as Arnold mentioned, is keeping older adults out of nursing homes, keeping them in the community. So one way of thinking, how do we do this, is looking at what disability is. It's not just an intrinsic matter. It's not just, let's say in Mrs. B's case, that she's weak. It's also the interaction between her and the environment, right? So disability is a gap between what a person can do and what their environment requires. And in her case, she's got quite a large gap, right? She can't reach into a closet to get her clothes. She can't just walk safely across her floor. And those things have to do with her environment. So she is more disabled because she's in that house than if she lived, let's say, in a ranch house that was brand new. But in the health system, we often tend to think of people just as individuals and that we just focus on their diseases. So we developed a program called Capable, where we targeted both what they could do and what their environment required of them, essentially. It's focused squarely on individual strengths and deficits and their goals in self-care. So Arnold talked a lot about patient-centered care and patient goals. We follow that approach, and it's client-directed as opposed to client-centered. You hear a lot at Hopkins and other places about patient-centered medical homes, which are great. I'm not knocking them, but that often means providing services around a patient, but we still have the same models of care. Do this, do that, take this medicine, without thinking, what are their goals? What do they want? And so Capable involves a handyman, a nurse, and an occupational therapist over 4 months' time. They get 4 nurse visits, 6 OT visits, and it's really a $1,200 handyman budget, $1,000 towards the house and $200 of assisted devices. And I mentioned it's 4 months. We collect data at the beginning and at the end. The occupational therapist starts the whole process, and the occupational therapist sits with the participant and goes over every single activity of daily living and instrumental activity of daily living. And I assume you know what those are, but they are essentially bathing, grooming, preparing food, managing your money, the basic things you have to be able to do if you are going to be able to stay out of a nursing home. And the occupational therapist also observes the person doing it. So if the person says, I have some difficulty getting in and out of the tub, they go to the bathroom and watch the person get out of the tub. What is the difficulty? What would you need in the home to help it be less difficult? So that visit's fairly long, as you might imagine. The second visit, they finalize the goals, what the person wants to do. It's not what the OT wants them to do. It's what the person wants to be able to do. I want to stand long enough to cook, or I want to be able to get down my front stairs into my daughter's car and be able to go to church. It's very function-focused. And also the occupational therapist does a house tour of the whole house. And together they come up with a prioritized list of what the changes the handyman will make. Then the OT writes a work order for the handyman, and I don't know if any of you know Civic Works, but they're a wonderful nonprofit in Baltimore. They're an AmeriCorps site. So the handyman is actually a contractor and an AmeriCorps apprentice who's often a woman, so it's not really right that we call it a handyman. Then the nurse starts at the end of the first month, and the nurse's domains are pain, depression, strength, balance, primary care provider, communication and advocacy, similar to the Coleman coaching, and medication management, adherence questions. We have many people who are on 26 medications, and they'll say, I'll take 4 of these, but which 4 should I take? And the nurse, it's very different than typical nursing care. There's none of, you need to be taking this medicine every day, you need to be checking your sugar every day. We're not their primary care provider. We're there to address the nursing parts of function. So the questions are things like, does your pain interfere with you getting down the stairs to get in your daughter's car to get to church, if that was your goal? Right? It's very function focused. Or is your mood such that you are too depressed to try to cook for yourself? So our assessment that we do is entirely function focused, but in those domains of pain and depression, primary care provider, communication. And let me tell you, it's a trick training new nurses to this approach, because they come in, they say, well, what about my goals? When do we get to talk about what I want them to do? And that's just not part of this model. So then the nurse and the OT sprinkle their visits throughout the rest of the 4 months, and typically someone has 3 OT goals and 3 nurse goals. Sometimes they're the same goal. We have someone who lives not too far away who had been sleeping on her couch right by her front door and was unable to get upstairs. And her main goal was to be able to sleep in her bed, which involved her being able to get up the stairs, right? So we put banisters on both sides so that she could distribute her weight. We did a lot of strengthening in her legs and a lot of pain management. And she can now sleep up there, which she loves. She can sleep better. And as you know, sleep is very relevant to other health outcomes. And she's getting the exercise of going up the stairs every day. She goes more than once a day She also lives in one of the scariest parts of Baltimore City and had no way of looking out her front door. It was just a wooden door. There were no windows, and so she was also just sleeping in a really fearful way. And when she answers the door, she just has to throw it open for whoever's there. So another thing we did, we put in a nice little window in her door. And just, the stress hormone decrease enough, I think, is part of what's making her feel a lot better. We did a pilot study, and I'll go over, I'll shorten it for time, but we can come back if you want. We did a randomized control pilot study, and all of this work is based on the skeleton of a program that was tested in Philadelphia 10 years ago called the Able program, which is why ours is called Capable. And they had the exact occupational therapy part and home modifications. We added home repairs and the nursing part. So we did the pilot study of that adaptation, but there's already been randomized controlled trials of the Able part, of the OT part. And they were mostly lived alone, mostly African American, and about 80, and limitations in more than 2 activities of daily living. And we had an attention control with the idea that what if people were getting better just by having a friendly OT or nurse coming to their home? We wanted to make sure that the outcomes we were finding weren't just from the decrease in social isolation. And we found, and I can't move, but we found that it made life easier, Capable made life easier and benefited them more than the control, but the control really liked it and thought it would help others also. And you can see in the red, we improved people's activities of daily living by 67%, and their instrumental activities of daily living by almost 50%, and their quality of life almost 40%. And so based on that pilot, we got one of the CMS Innovation Grants. There were 108 funded throughout the country, and Hopkins got 2, as I mentioned. And the nice thing about that is it's through the Affordable Care Act, and it's written right into the Affordable Care Act that if the actuaries at CMS decide that a project both improved people's lives and saved money, you can't do just one or the other, that they can scale it up nationally with a stroke of a pen. Just CMS, it doesn't have to go back through Congress the way all the Medicare demonstration projects used to. And we're finding Capable averages about $3,300 a person. And as Arnold mentioned, nursing home is about $70. And a hospitalization is about $15,000. So if we can just avert a fifth of a hospitalization for each person, we will have saved money. And so far, this is another thing about the CMS grant. They view it as with a continuous quality improvement idea. It's very different than an NIH trial. We have an NIH trial also ongoing of the same project that's a randomized controlled trial. But for the CMS one, they want us to be looking at outcomes every quarter. We report to them, and then we're supposed to tweak things. And so it's nice because we have some early results, whereas with the NIH, we can't unblind until we're done with it, so we have no results yet as we go forward with the NIH trial. But so we're finding so if you look on the right, the blue is at baseline. Only 5 of the 52 said they were in no pain at the beginning, which I think is really remarkable. You can see between moderate and extreme, almost everyone is in pain in this sample. They're older adults. These are dually eligible Medicaid and Medicare folks. And you can see we more than doubled the number of people in no pain by the end, and we decreased both the extreme and moderate. Not hugely, but the effect is there. On depression, now we don't give antidepressants, but this decrease is clinically significant in the PHQ-9, and it's about the same as an antidepressant. And in case you're not used to spaghetti plots, each one of these lines is a different individual, and then the red line is the average of them all together. And this is kind of the money slide. This is activities of daily living difficulties. We cut them in half, the number of domains of people saying they had difficulty, from a 4 to a 2, a little more than a 4 to a 2. And so we feel very excited about the possibilities for this. Another way of looking at it is that almost 80% of people improved in their ADL status. And this is older adults, frail, dually eligible older adults. You would expect them to be either staying the same or getting worse. And with IADLs, 63% improved over the 4 months. As I mentioned, we also have an R01 from NIH, And that has the same design as the pilot, where we do have a control group. And the participants in the control group love their control group, too. They get 10 visits at home, just like the capable group, and it's also based on what they want to be able to do, but it's all cognitive. And so that's the difference, so we can try to measure the differences. And we are looking at the 4-month follow-up and then also 52-week follow-up, because it wouldn't be so great if we just improve people temporarily and they go right back to how they were. So we want to see about long-term. And then in both the CMS trial and the NIH one, we have healthcare costs. We've got everyone's claims data, what we're building up, to be able to look at the differences. This is one of our participants who hadn't been in her basement in years and now can go down to take care of her laundry. So just as Arnold said, this is just a shockingly historic time. And I think that it's hard to see that sometimes because we're all so busy and just thinking about our own sphere. But the combination of the demographics of older adults and the fact that medical costs are skyrocketing and the Affordable Care Act changes so much towards prevention. And for any nurses in the office, in the room, we're really poised to work at the top of our licenses because of the Affordable Care Act and because of the Institute of Medicine Future of Nursing report, that we have to crack this nut. We have to get people from Arnold's slide of nursing home into those other services, and this is one approach to try to do that. Also, I'm sure you're aware that the hospital payments in Maryland are going to change to being much more preventive, where hospitals will know what they're budgeted. And they won't be reliant on people being admitted, so that the financial incentives are going to change. And you can imagine a time where Bayview, for example, might say, we'd like to pay for 50 capable slots out of our budget that we know we're going to have because we think we can avert more than 50 hospitalizations. And also in state-level policy, Michigan is starting to roll out a pilot of capable within their Medicaid waiver. I remember Arnold was talking about the home and community-based services waiver. They're testing it in Michigan because they think they can save their waiver money, and they then want to roll it out statewide throughout Michigan in the year following. So I just wanted to end with a participant that's not her real name, and her main goal was to be able to walk around Lake Monta Bella. For those of you who live in the city, you may know it, and we thought that was wildly unrealistic at first, but that was her goal, and she had a combination of she was quite weak, and she didn't feel like she could leave the house because she was taking care of a husband. And we helped her problem solve and get more supports for taking care of the husband. She can now take care of herself and get all the way around the lake, and she's also showing you the equipment we got for her bathing. So that's all. And we're nicely funded by a number of groups that we're very grateful to, and we have incredible staff and students and wonderful co-investigators, one of whom's in the room now, Ivy Tanner. And these are the questions for the website, folks. Thanks.
Those were two great presentations, and I think it was particularly interesting to get a kind of dense, good overview of the whole picture, and then a look at something specific. And we really appreciate both of the presentations. And for those of you particularly who want to look into Mr. Eppel's PowerPoint more closely, by tomorrow the PowerPoints will be on our website. And in 2 to 3 weeks, the archive will be. So I'm going to start out with any questions in the live audience. You can just raise your hand, and we'll bring you the microphone. And please be sure to wait until you get the microphone so people online can hear the question. Any questions from the live audience? Not yet? Is that that's a wave, not a question. Okay, well, there are a couple of questions online, and one is for you, Sarah, and it has to do with the model and the client-centered. And the question is, what is the role of the family or family caretaker in setting the goals and in making the model work?
That's a great question, and it's something that we're continually working on. Right now, the participants in Capable are all cognitively intact because it's very goal-oriented and problem-solving oriented and generalizing strategies from one problem to another. And family members are involved to the extent that they want to be and that the participant wants them to be. Because family members are human beings, we find extraordinary range from family members who are very helpful to family members who are neglectful to family members who are too helpful. You know, someone wants to be able to cook. No, don't, I'll do everything for you kind of thing. And so we're really feeling our way in terms of the goal setting with the family as well. But Capable is firmly around what the participant wants. Just like Arnold was saying, if someone wants to move out of the nursing home, that's up to them. We certainly, one of the things, we have Capable exercises that are based on the Otago exercise. They're from New Zealand. They're geared towards fall prevention. There are a lot of core strengthening. And we do find that when family members do them with older adults, the older adults are more likely to stick with them. So we try to involve older adults as we can, but we don't have specific family goals.
Okay. Here's a question for Arnold. How does the nursing home industry feel about some of the innovations keeping people out of nursing homes? And are nursing home businesses moving into more assisted living or a more community-based model?
So I think that's a better question for HFAM and Lifespan, who are the lobby groups for nursing homes. I can only tell you that it appears that a lot of the beds are moving towards some rehab, short-term rehab programming and services for those folks needing to leave the hospital to get rehab. I think with the change in the population and the demographics that are going to be, really ramping up, that I don't think the nursing home really has a whole lot to worry about as time moves on. I think that what we're not seeing is CONs for new nursing homes is what we're not seeing, which you would predict you would see with this baby boom ramp up that's going to happen or is already in process. I ran an assisted living, and we expected all kinds of business starting in 2010. And there's a big resistance to assisted living by the individual, not necessarily the family. So I would say to you, I'm not really too concerned about nursing homes losing business. I'm sure that there'll be plenty of business in the future for the industry.
Okay. Any questions from the live audience? No, I don't want to ignore you all. Okay. There is another question. This one is for Sarah. Even though you can save money, will Medicare be willing to pay prospectively for comprehensive in-home services? And are these programs scalable?
Those are great questions. So whether Medicaid or Medicare will be willing to do it, I think we'll find out. They're supposed to, and I was just talking with someone from the Innovation Center this morning who said that if we definitely demonstrate that it saves money, that they will. I think it'll be interesting to see whether health care dollars will really be spent on housing improvement. They should be, and we all know that our housing is health. But it'll be groundbreaking if they do. I've forgotten what the second question was.
Whether the model was scalable?
Oh, so another excellent question. There are not nearly enough occupational therapists in this country, period, let alone capable, just in terms of the need. And as the demographics are changing, that will be even more true. And there's always a nursing shortage, but there's a much more severe occupational therapy shortage. And in fact, with our partners in Michigan who want to scale up capable, they're starting in an occupational therapy-rich area on purpose because they're worried that they won't be able to scale it. It is scalable in terms of being teachable, and we've got all kinds of forms, and we're developing trainings, but I think that we all need to go lobby for more occupational therapists.
Okay. There's another question about, you talked about patients in nursing homes. I guess this is for both of you, having the opportunity to be reevaluated and to move back into their homes. And you talked about housing subsidies, but would there be a large enough subsidy for a person who doesn't have a home to go back to and essentially would need to be renting an apartment or
And those dollars are part of the folks that, once they're in the nursing home, and they're not eligible if they're not in the nursing home. If they're in the nursing home and they want to leave, I want to say it's about $3,100. And yes, it's available for folks to initially find the location. It may even be just the security deposit. It may be money for a bed. It may be for a dresser, for some kitchen utensils, etc. So the answer to the question is yes. We work with peer mentors to help those folks get out so they can have the confidence. I've seen one where, 8 hours after they moved out, they came right back, and it didn't work. And we spent the money on the, some of the furniture, et cetera, et cetera. So while it may be a dream, it's sometimes not reality. Many times it's going to take the family be involved. Caregiving is such an important role that as well. So, if without the necessary support in the community, whether it's the $3,100 to make it happen, but it's going to be more than that. And yes, the assisted living is another option for that family to go to.
So then it wouldn't be long-term rent. In other words,
no, they won't pay the rent on a monthly basis, to answer the question. Correct.
Okay.
You have to have the sustainability, whether it's your Social Security check, et cetera.
Okay. Any questions from the live audience?
Hi. I was wondering, in terms of the advanced directives that you were talking about, I'm familiar a little bit with what Dan Morheim, one of our state legislators, has been doing. Can you say a little bit, I guess, in terms of where his work is and how it works with what you're doing?
So yeah, I've worked with Dan in the past, especially in the area of hospice. And as far as advanced directives, there's, the Attorney General has a website which has a very sophisticated 26 pages. You've got to read it. And while I won't tell you that it's not excellent, it creates a lot of questions, and you fill out the form and you feel like, did I do a good job? There's another document called 5 Wishes. You can Google that, and it's a good document. It costs $5, and you can fill it out. There is another website, and I don't remember the name off the top of my head, mydirectives.com, I think it is. An excellent website where you can log your advanced directives online. So, for example, we also know LegalZoom's out there where you can put an advanced directive up. But mydirectives.com has the ability to actually have a password. And so when you go into the hospital and your children can't find the advanced directives, you can't find the advanced directives, this mydirectives.com has the opportunity with a password of downloading the advanced directive online real time, which is kind of nice because then you could actually implement it with the care. Does that answer your question?
Okay, there's a question right there.
Hi, this is a question, I think, for Arnold. I know most people want to stay at home as they age, but I work as a geriatric care manager for faculty and staff here at Hopkins, and there are also lots of people, as you know, that want to go into assisted living, and that would be an appropriate level of care for them. But I guess if you could say something about the financial, if you see any changes in financing strategies on the horizon, because it's not affordable for so many people. They would qualify for Medicaid if they needed nursing home care. I mean, financially they would qualify for that. They are too sick for independent living and can't, manage there. So what do you think about that huge group of people in the middle?
Let's talk about people of all ends. Okay, so under the Medicaid Waiver Program, they're now eligible, whether they're in the older adults waiver or the living at home waiver now merged, assisted living's covered. So that's kind of cool and a big change for the 18 plus disabled who've been in the nursing home, want to go out. Maybe assisted living's a less restrictive environment. So that's a good change. For folks we saw a 20% increase Baltimore City. I suspect that's a national pattern of assisted livings popping up all over, 1 to 4 person homes, 4 to 15s, et cetera. Many of those will take the Social Security check. And in fact, in the new resource directory 2014, the list went from 1 page to 2 pages. And I'm not saying they're all going to take the Social Security check, but in our jurisdiction, sometimes the Social Security check is all we have. And when you have a business model of assisted living, it's a profit-based typically. Those folks might want to pick 4 folks out and all with their Social Security check, and now they have $5,000, let's say, coming in, where they could run their assisted living period in a smaller environment. Now that's just all out of pocket. And then there are the folks that lived where I ran a community and paid anywhere between $4,500 to $6,800 to live in assisted living, and that's all out of pocket. I tell people about long-term care insurance, and we've watched people stop selling. A number of companies have pulled out of that. So I will say to you that it's all the spectrum. It's all over the place. I don't want to say you get what you pay for, because it's really about. I always say it's all about a leader or the director. I always ask whenever, and I just toured someone through an assisted living, a family member that has polio with childhood, older, 85, needed to pick a spot. It's all about the director. How long has the director been there? How committed is the director to assisted living? Do they live close by? Do they live on site? Ask the director everything. And if the director, you never meet the director, don't move in. So those are some tips I would say in shopping assisted living, and the best I can tell you in various mid to level ends of buying it.
But for policy, you don't see any changes for people who are in the community now and want to move to assisted living but can't afford.
We have an assisted living subsidy, grand total, drum roll, 23 people. That's all and we have a wait list for it. And it only pays $650 towards it. No, I don't see that we're going to see big changes in the AL industry as far as public funding for it in a very large way. I don't think the economics of aging are there for it because of the costs.
Just following up on that question, I mean, looking at the spectrum of services and population shifts that you're talking about, wouldn't it seem that there would be a political push for more funding for assisted living, given this big group of people that are probably healthier as they age than past populations and caught in that middle spot?
So let me just say this to you. So from 1980 to 2012, I think the number is, we've gone from $9.80 per person in our country for Older Americans Act funding, which is a grant that funds meals and et cetera in the community. We're down to $3.30. So instead of while we're watching a population boom, we're watching level funding, more people coming in, and less dollars available. So I don't think we're going to see, it makes sense, but I just don't think that the economics are there. We're looking at, I always say when you look at aging services, because we spend a lot on Medicare, children in schools, police and fire, recreation and parks, where does aging fit in that spectrum? When you're looking at public dollars, how do you spend health, hospitals, where do you spend the money? And unfortunately, because Medicare eats up so much of it, the Medicaid dollars shifted for 80% being long-term care for older adults. I don't see that we're going to see a big change in AL and more dollars for older services. That's my opinion. I could be totally wrong. Sarah?
Okay, so we know what work lies ahead. Any more questions from the live audience now? I have a couple more from online. One has to do, Arnold, you just talked about the chronic disease self-management model and about developing sort of peer community leaders. And the question has to do with, it's sort of two-part. One is how you recruit those leaders, and the second is there a formal relationship with schools of nursing that has nursing students going out and doing the sessions, the training?
So we've developed, I'll answer the last one first.
Okay.
We developed a relationship with Coppin, who's been working with us this last year as we're trying to put a model together, and then we're going to go out to some other schools and hospitals, including Hopkins, to assist us in the CDSMP model. You have the Stanford University program, CDSMP, requires that we have trained the trainers and that we have folks that have gone through the course, which unfortunately we've lost a few people to the private sector, and we have just finished rebuilding our program to continue this project. We get prior participants to be part of the next class, and that's kind of how we do the peer-to-peer. And then they share their various tricks, I call them, or ways of coping with their chronic disease with other folks that say, oh, I didn't know that, then maybe I should try that. I've seen someone say, cinnamon reduces your blood sugar. And one says, really? And then, so it's kind of like different ideas come up in the program. And then it's led through working with nurses in their final year who have to do their internships in the program. I would ask you to call Eloise Maine. I can give you a phone number, 410-396. Call the CARE number, C-A-R-E. Ask to speak to Eloise Maine about developing the CDSMP in Baltimore City. The list of numbers that you'll see when it'll go up live has all the other phone numbers of all the other jurisdictions, and they also have a CDSMP program in their area agency.
Okay. Did you have a question?
So for the Capable program, I heard you talk about depression, and I wasn't sure if you have an elderly person who is too depressed to set their own goals, does that mean they don't qualify for the program, or is there a way that you help them?
No, sadly we have many people with depressive symptoms in Capable, and if you're familiar with the trans-theoretical model of change, where people are in pre-contemplation or contemplation, so we stage people by our clinical judgment for their ability to set goals and where they are, and certainly mood is a part of that. And sometimes we'll have people who just really can't set goals, or they can, but they don't have the want to, as some people say, while we're not there to work on them. But we've just been so impressed with the ability to budge those symptoms. And I think it has to do with focusing on what they want and on the tangible changes to the home. I was on a site visit recently. We had Dr. Herrera, who's with the State Health Department. She came out with us, and we rang the doorbell, and the participant didn't answer. And I thought, do we have the wrong place? And we were waiting on the porch, and she answered, and she was in tears, and she was going like this. And the OT who was there had just put in a raised toilet seat, and she was just crying, talking about how she used to hold her urine as long as she could because it's so painful to get up from the toilet. And if you think about it, a toilet is a very low chair with no arms that you have to use multiple times a day. And, to healthy people, we don't think of it. You just get down, you get back up. But it is very difficult for people. And people are grabbing onto towel racks and this bathroom is the most dangerous place to fall. So the reason I mentioned that story is that by attacking all kinds of aspects of their home and their other goals, that's part of lifting their depressive symptoms. And then as you meet a small goal, it's easier to think of a new goal.
Okay, there's another question online. This is for you, Arnold. Because there's significant differences between Baltimore City and Baltimore County in providing services for aging and disabled individuals, why were these two entities combined as a regional consortium to provide these services?
So I'm not sure that there's significant differences. I operated the Baltimore County Department of Aging for 20 years, and I'm working inside the Baltimore City Health Department Office of Aging. And it's a little different because actually the health department inside the Office of Aging inside the health department has actually allowed us to do something what I call warm handoffs. So when I have someone calling and I need an ARS assessment, I would have had to refer that to the county health department, then tried to follow up through. This way I can hand it off, and in 2 days I can follow up and then try to merge it into the separate service. Now, what are differences? Such as in Baltimore County, they have something called County Ride, which Baltimore City doesn't have, because we don't have that kind of rural outreach that people need to get to hospitals and doctors. We have taxi access. We also have a fixed transit route that's pretty substantial in Baltimore City via the buses and the subway and light rail, et cetera. So I'm not sure exactly some of the services that we're missing. I will tell you there are differences in our senior centers, but in Baltimore County, Baltimore City, the resources are the same for the nonprofits, for the home health agencies, for the personal care attendants, for the just about almost every exterior service that you might be looking for, durable medical equipment, are pretty much the same. So it's a natural progression of putting those two together, summary of services, and seeing what works together as opposed to us doing things separate and utilizing economies of scale. Makes sense.
Okay, here's a question for Sarah. Please expand on the methodology of strength training and involvement of PT. Is it all done in the home, and is any lightweight training involved?
So the strength training, the occupational therapist on the second visit does a PT screen to see if we should send someone to physical therapy, give them a referral to physical therapy. So that's part of it. We don't have a physical therapist on the team. And then the nurse introduces these capable exercises that are based on Otago on the second visit of the nurse. And the basic ones are very low level. They're things like the choir clap where you turn like this, or raising your knee. So they are using muscles, but they're not using external weights. If someone is already beyond that, we have some fairly active people, then we introduce the Fit for Life, which is part of the NIH exercise program. And of course, if someone wants to do, sometimes someone will say, I want to sign up for Silver Sneakers at the Y, or I want to get to the league, but I don't know how. We work on trying to get them to the highest level of exercise that they want to do.
Okay. Any questions from the live audience? No? Okay, there's another question online dealing with volunteer or family caregivers. And if any, do any of these programs address the healthcare dynamics, the health dynamics of a person being a caregiver, and provide, for example, for breaks for care for the primary patient, so the caregiver can leave the home for certain periods, or any kind of services for caregivers?
I guess I'll start, and then you can. So a number of our participants have been older adults who are caregivers of others in the home. One person I'm thinking of now, she's in her early 70s and takes care of her 93-year-old mom who has dementia. And so being able to keep her healthy keeps her mom in the house too. So it's a twofer. We have many situations like that, or spouses where they're both 80 and one has dementia and the other doesn't, and we have the one without dementia or capable, and he's making his own goals, and we're improving the house for both of them. But we haven't done it in a structured way of seeking out caregivers, and we don't have money for respite care, for example. But if we help them find resources. But I bet Arnold has a bit more comprehensive answer.
So under the Medicaid waiver, one of the changes in the Medicaid waiver is the elimination of the respite reimbursement. So just heads up, FYI, while we saw the merger of the waiver, one of the changes, reductions, is the subsidy for that. Which I've already heard from a number of folks about, and saying how difficult that becomes. And I said, but we're going to help more people, and that's important. So there's a couple of programs. One's called a caregiver subsidy that we offer through the Older Americans Act. And it's a subsidy that you can apply for. It's $300. It was as high as $500. Baltimore City lost $1 million last year based on census to Montgomery and Prince George's County because of a census change. So I've had to reduce that subsidy from $500 to $300. But it is there, so there's a caregiver subsidy that one can apply for. We're doing a caregiver conference. In fact, I'm trying to plan for it now with about 400 folks. Tips, tricks, best practices, therapy, how to utilize an occupational therapist. And the Weinberg Foundation has done a remarkable job of looking at Maryland, and this is what's going to happen in the next few years, trying to make it one of they've done some studies around the nation showing that caregivers can be a really important model to keeping people home, as well as home repairs. Small handyman services will keep someone home longer than probably any other project or program. However, without a caregiver, many times people can't do anything isolated and alone. Baltimore City has a very high older adult population living alone for many reasons. Premature death, divorce, marriage, etc. And so caregiving is an important tool that we've been developing. In fact, we're running a whole 2014 campaign called STEPS, Stepping Toward Emotional and Physical Success, that builds information about the caregiver and how to seek assistance and how never to say, no, I don't need any help, versus the other, yes, I need help, whether it's the caregiver needing help or the individual. We also have something called the Senior Companion Program that we have a grant and a program for that people should know about. That may be helpful with the subsidy program. And then there's the RSVP volunteer project. So there's a number of tools. Is there enough? There's never enough. But there are a couple things that you can avail yourselves to learn more about. And Capable being one of probably the greatest programs for the handyman project that'll keep someone home, and a caregiving model to go along with it.
To follow up on the resource question, the resource guide that you mentioned, the 2014 version,
Yep.
Besides being available online, will hard copies be available?
There'll be 50,000 in Baltimore County, about 25 to 28,000 in Baltimore City. If you're looking to pick up a copy, you can actually come up. I'm going to tell you by February 1st, you could come up to the Benton Building on 417 East Fayette, 6th floor, and pick up 25, 50 for your organization, or if you're a hospital discharge planner, you need some more, we can certainly make them available for you. But yes, there'll be hard copies as well. It's the nice piece about that tool is a lot of benefits are in the back, Quimby's and Slimby's. If you don't know what Quimby and Slimby is, it's the Medicare Part B payment that can be made on your behalf if you're eligible under Medicaid that comes out of your Social Security check. It's about $104 a month. There's just SNAP and information, income asset limit testings are all there, so it's right there. And you just have to get an application and fill it out, the hard part. It's not so easy to fill out these applications. They're difficult, and a lot of them are annual. So you fill it out this year, you get it, and all of a sudden it cuts off. And you got to go through the whole process again. It's very, I call it, it's purposeful versus, well, why would we have to do it again every year? It's purposeful. To make you apply to get that benefit again, to weed out the next person, but you have to stay on top of it.
Okay. Any audience questions? There's one more question online, which has to do with, you spoke about hospice care and advanced directives, and the role of primary care practitioners, whether they be family medicine, internists, nurse practitioners, in doing education about advanced directives. And if any of the health profession groups have that as, excuse me, as part of their intake or part of their exam as people reach a certain age?
It's a great question. I'm not sure I have the answer for it. All I know is that when you go into an emergency room into a hospital, one of the first questions they ask you is, you have an advanced directive. And we saw the numbers. Most people are going to say no, but I was thinking about getting one. But I don't have the answer to your question. I can tell you that we've watched some physicians now take over some hospice organizations. My mind's eye goes to Seasons, for example. Dr. Gary Applebaum is now the CEO of that. But I don't know that education of physicians have been a primary. I don't know, Sarah.
Dr. Tanner in the audience could answer that question.
Wonderful.
Short and sweet. Healthcare organizations and healthcare providers within organizations are required to ask if people do have an advanced directive and to offer to assist in making that available to them if they are interested and don't have.
Is that at a certain point in care or at annual visits?
Admission to a healthcare institution and hospital and within a practice.
So within primary care practice? Okay. Okay, are there any more questions? We don't have any more online, and we're just about at the end of our time. So I want to thank both Arnold and Sarah very much for a really stimulating conversation. I know I'm going to spend a lot of time on the looking on the web now at all of these resources that are available, and it's wonderful to know what's out there and what the future picture is, and also to know where the gaps are and where the work is moving forward. So thank you both very much. And I hope everyone will put on their calendars our next Grand Rounds, which is February 19th, and we'll address domestic violence. And you can just mark your calendars, if you like, for the third Wednesday of every month at noon. Okay, thank you.